Well, good morning. It's great fun to be here. Thank you, Bill. With lots of old friends in the perfusion community, I'm so glad to see all of you again. I really enjoy going to talk to perfusionists or nurses or ECMO specialists because you're the people who actually do the work. Number one, you understand the physiology, which is rare. And number two, you're willing to work hard and you can see the results. So it's a special treat to be here at this sort of a meeting. We're going to talk about ECMO in the future, which is a great topic. Thank you, Bill, for that, because I don't have to show you any data. I can just say, here's what I think is coming. Some of this we're working on in the lab, and some of it is already established clinically and moving to broader application. So you're all device people, so talk about the technology and devices first. So we used roller pumps for years, as you all know. The only disadvantage was they could blow out on the high pressure side. We all switched to centrifugal pumps. They can't blow out on the high pressure side, usually. The disadvantage is they can suck too hard on the inlet side and cause hemolysis and thrombosis. You all know that. And so we need to improve the pump system in order to, that's the key to automating the entire prolonged perfusion system, and I'll tell you a bit about peristaltic pumps, which solve all the problems of the centrifugal pump and the roller pump. So the other factor is to develop a controller. Now, we have perfect controllers for control of blood flow, sweep flow, so on, all dependent on physiology, and you are it. So your brains are the things that automate this system, and we all like that, but it would be nice to let you be a consultant rather than the actual doer. So ways to servo-regulate the system so it all happens automatically without having to think about it is where some of the future will go regarding to pumps. So I've mentioned roller pumps and centrifugal pumps. The ideal pump would be ultimately safe by its inherent design and servo-regulated by its inherent design. So the pump that accomplishes that is a peristaltic pump. If you've been around a long time, you might have used the Rhone-Poulenc pump from France, no longer available. There's one company that's making this pump. It's called MC3. It's a company I started about 30 years ago. I can tell you this freely now because MC3 has kind of given up on the M pumps, sadly. So if you work with a good entrepreneurial company, this is now available and will eventually find its way into practice. The way a peristaltic pump works is it's a roller pump, but there's no backplate, and the chamber is normally flaccid. So it fills by gravity drainage, and it only pumps what's delivered to it. It can't blow out, it can't suck too hard, it doesn't cause hemolysis, and it's the ideal pump for cardiac perfusion, as a matter of fact. Did any of you use the M pump when it was available? A couple people, so you remember it was great, wasn't it, when you could use it? Little company called the Avicor company in Minneapolis made it. Medtronic bought it and put it on the shelf because they feared the competition. But now Medtronic can buy it again, Peter, and make it work. So how about oxygenators? Oxygenators work pretty well. We're all settled down now to blood outside hollow fiber devices. The reason we all use those is because they're easier to manufacture, but it makes it really an ideal artificial lung system. Several centers are working on microfluidic lungs, that is to make the gas exchange chambers about 10 microns in size, so the red cells have to go through one at a time. Technically, this ought to be fantastic. Practically, I think it'll never work, or I did until people showed it does work. So that may be the membrane lung of the future. We only need 3 sizes of membrane lungs, as you know, that are rated flow at about 1, 3, and 6 liters a minute for all purposes. And of course, as you all know, but most clinicians don't understand, is that the CO2 regulation is all controlled by the sweep flow. It's unrelated to the composition of the sweep flow or the oxygenator or anything else. It's just like the lung. The more you ventilate it, the more you can blow off CO2. But it ought to be able to measure the amount of CO2 that comes out and servo-regulate that back to the sweep gas inflow, which can in fact be done so you can control CO2 excretion right down to the last cc. And finally, anticoagulation remains the biggest complication. It's less than it used to be now, but bleeding and clotting and anticoagulation is the major problem with prolonged support. So there are two things that are happening there that will change all of that to some extent. One is to get away from heparin and use direct thrombin inhibitors. Bivalirudin or argatroban are the drugs. Centers that are doing that are finding it's much easier to regulate anticoagulation, much less hours spent with the hematologist who tries to tell you that measuring anti-10A is somehow useful, which it's not. And that's coming, and if you haven't done that in your center, do it, learn about it, and switch to either bival or argatroban. More important than that is to change the surface characteristics so we can build devices that won't clot. And there's been a lot of work on that over 50 years. None of it has worked yet. Heparin-bound surfaces, albumin-bound surfaces help a little bit, but really don't eliminate the need for systemic anticoagulation. We have ways of doing that that are quite effective. Tomorrow, Gail Onick is going to be here and talk about that. She knows all about it, so listen to what she has to say. One interesting, the chemistry that we're using to prevent platelets from sticking to the surfaces is nitric oxide gas eluted by the plastic. This is how your own normal endothelium prevents clotting, and this will find its way into clinical practice. Because of this audience, I'll just show you this, and I trust you're all up to date on this, but if you put nitric oxide in the sweep gas during cardiopulmonary bypass, it prevents SIRS. So this big randomized trial from Australia, there are 2 more trials now underway showing that post-operative renal failure, cardiac failure, and so on, you can almost eliminate it by putting nitric oxide in the sweep gas during bypass. Why is that? Why should that work? Isn't that fascinating? The graphs on your right show work from our lab showing that the reason that works is that it prevents white cell activation. So all of that inflammation that occurs post-CPB is all related to white cell activation. All of that is related to air interface. It doesn't happen with ECMO, it only happens with CPB, but you can prevent it with nitric oxide. This is all laboratory stuff, now finding its way to the clinic, but very interesting. So with those new devices and approaches on the horizon, what will the use of prolonged support look like in about 10 years from now? Well, for circulatory support, we'll still be doing all the things we're doing now in the yellow here, but what's growing rapidly is the use of ECMO for cardiac arrest, so-called ECPR, and the use in septic shock. And there are new applications which you will have to get involved with that have to do with using ECMO to resuscitate transplantable organs in people who are dead because their hearts stop. So interesting stuff. So ECPR, you've all been involved with this, patients on CPR, and if you add VA ECMO to it, the survival rate goes from about 2% to about 30%, and these are examples in neonatal, pediatric, and adult populations. But the place where this is growing is in emergency departments. Let me just ask you, how many of you work in big hospitals, have your ER docs come around to say, we want to do ECMO in the ER? Very many? Maybe a dozen. It's going to happen to all of you, I hate to tell you. So what it means is you have to teach everyone in the emergency department, not just the docs, but the nurses and the techs and the ambulance drivers and the EMS people, how to get patients to the hospital in a hurry, how to get them cannulated, how to get them on VA ECMO support. And like it or not, this is happening around the world, and it will happen in your hospital. My advice is don't let it happen as a surprise. You have to plan for this. It takes about a year to get the cardiac cath lab and the blood bank and the ICUs involved and do this as an algorithm. If you do it just in the ER, it's a disaster. You do 10 cases and whether they live or die doesn't matter. It disrupts the hospital too much. So you have to get it organized at the whole hospital level. This is now old stuff, and some of you may be involved with this, but if someone dies by virtue of cardiac arrest, if you come around after some time and put that now cadaver on VA ECMO, you can resuscitate the kidneys, livers, lungs, and eventually the heart for transplantation. So we've been doing this at Michigan for a long time. This is our data on 37 DCD donors. These are controlled donors. These are people that we're going to, their hearts work all right. We're going to terminate their life support, usually because they're in vegetative state, but they don't meet the definition of brain death. So after they die, put them on VA support and harvest organs for transplant, and they work really well. So we've done kidneys and livers and pancreas, soon to do lungs, and we're working on how to do hearts in the laboratory. And finally, the other application that's coming a lot is the use of ECMO in septic shock. This is just the data from the first such papers, been about 10 years ago now, from Australia. You need, I always thought, why would VA ECMO would be valuable in septic shock? These people are already in high cardiac output. They have vasoplegia. This is the new word. So you're not with it unless you know about vasoplegia. It just means you can't give enough norepinephrine to raise the blood pressure. But what these guys in Australia showed is you put those patients on VA bypass at very high flow, usually requires central cannulation. What do you know? A lot of them get better. Amazing. And a lot of other people have now corroborated this, so this is happening around the world, and your ECMO team is going to be more and more asked to put patients on whose only problem is they're in septic shock. Usually they're in respiratory failure at the same time, so you've already had a lot of experience with this, with someone in profound respiratory failure who's also in septic shock. The question is, should you just put them on VV like we usually do, or should you go to central cannulation, high flow VA? And that's all being studied. It's interesting stuff. So in the category of respiratory support, 10 years from now, we'll be doing all the things we're doing now, listed here in yellow. But this is where the research biology interest is really coming in, the use of acute respiratory failure moving to chronic support, and what to do with those patients. Transplant them, as Dr. Bermudez just said, this is now happening, or might they get better? This is the really interesting stuff. So one of the respiratory support ideas is selective CO2 removal. This comes back about every decade as the hot new stuff, as new intensivists read the old literature. But it's been around since '86. Luciano Gattinoni and other colleagues working in Ted Colabo's lab developed this concept, really demonstrated you can separate oxygenation and respiration physiologically, so you can study them independently. By the way, all of you should be aware of the fact that Ted Colabo died about 2 weeks ago. Colabo was really the father of ECMO, if there is such a person. He invented the membrane lungs, invented the cannulas, did all the animal studies, never treated a patient. He was a research doctor at NIH, but a marvelous, marvelous man. And you'll hear about him when you come to ASIO or ELSO, things like that. At any rate, the latest iteration of this is a device called A-Lung, or it's called Hemolung, made by a company called A-Lung in Pittsburgh. Great company, really good people. And it's really just a mini ECMO machine that's designed for blood flows about 500 cc's a minute. but that's plenty to get rid of all the metabolically produced CO2. So there are clinical trials underway in Europe and in the US for end-stage lung disease, for emphysema. This is where the application comes, maybe as a bridge to transplant, maybe as a bridge to recovery. The problem, of course, with it is that these patients, they're dying of CO2 retention. You put them on, they get better, they wake up, it's wonderful, this is really great. Oh, now what? They go back home again, 2 weeks later they're back because you haven't solved their emphysema problem. So that's where Dr. Bermudez comes in. This group of patients usually are not good candidates for transplantation. They're too old, they're too fat, they smoke, and so on. But this is the place where implantable or wearable artificial lungs will have a place in the future. No one wants to transplant them, but we need a palliative system in order to permanently, at least for months at a time, remove CO2 with an implanted device, and that's coming. And then finally, this information. This is the tidal volume of a patient with ARDS, a patient of Polly Palmer. If you're in this field, you know him from Stockholm. And here's a picture of the patient up in the upper corner. Important things, this patient had no lung function, no air going in and out for about 50 days. Now, we used to quit after 2 weeks or 3 weeks or a month or a period of time, say this is irreversible, total whiteout, and so on. Polly being Polly, hey, let's just keep going and see what happens. They go into right heart failure is what happens. They switch to VA, let's just keep going and see what do you know? A lung gets better every now and then. Here's this patient, and it happens this way. It goes along when nothing happened, and then in 2 days, bingo, they're back to normal tidal volume, normal breathing. A year later, they're healthy. Who would have guessed this? This is all new lung biology, and there have been hundreds of cases that have been on ECMO support of one type or another for more than 3 weeks of time. Tom Brogan summarized the pediatric literature, found 38% survival in children that had been on ECMO longer than 3 weeks. And in fact, a lot of the patients who died after 3 weeks died just because someone quit. Let's just turn them off. So we're just learning about this. There's a group from Maryland that's done a lot of long cases. Here are some case reports of days on ECMO with recovery, ending up in 605 days. This is the current record. This little girl here in front was at Hopkins, treated by Chris Nelson, the doctor standing right behind her in that picture. And she has a long history, but the important thing is she was on VA ECMO for cardiac arrest, then VV for lung failure, then RA to PA with the pump for a year for combined lung failure and right ventricular failure, then back on VV for CO2 removal, then off, and she's now healthy and doing well. 600 days. Who would have guessed that? So there's something that we're learning about now about reversibility of severe acute lung injury. The lung has remarkable regenerative capacity, which we really never realized. When we had this occasional anecdote, but now we're just setting out to learn how frequently this happens. And surprisingly, a year or two later, they have minimal disability, really do fine. So there are new scientific opportunities. How does that happen? Can you treat the lung with stem cells? No, they tried this a lot. It doesn't work, at least so far. But the lung itself can recover if you wait long enough. How do you determine which patient will recover and which patient should be transplanted instead? And most importantly, this leads to new practical problems. So you've got a patient in your ICU who's been on ECMO for 40 days, and now there's another one who's on for 3 weeks, and now what happens is the cardiac surgeon can't operate because there's no ICU bed. That's the best thing that could happen in this field, because the only person who would go down and bang on the desk of the administrator and say, "You're fired unless I can operate," the administrator will be fired, is the cardiac surgeon. So you work with cardiac surgeons all the time. I'm one. I'm sorry. You've all learned to deal with that. So you're sort of unusual. The rest of the hospital, internists especially, are just intimidated by that. But they get what they want, because well, the patient needs a heart operation. My God, it might be you. So you can get them to build your ICU for the 2-year ECMO patients and stuff like that. So take advantage of it when you're getting pressed to get into these very long cases. What I think will happen is that there'll be patients with acute lung failure who've been on for about 7 to 10 days. They're no better. So now they'll go to a place that's just good at doing this. Also, there'll be patients with end-stage COPD who need chronic support, where these things are under research investigation. So there will evolve to be several lung failure centers around the country where these chronic patients will be, and where we'll learn about this. Some of them will ultimately be extubated, some of them will have implanted artificial lungs, some of them will get transplanted. And will there be such a thing as destination ECMO, home ECMO? Sounds kind of crazy. The Swedes have already done this. So the answer to this is going to be wearable or implantable membrane devices, basically artificial lungs. And we've been at this for a long time. This is what we've been doing in Michigan, a group in Osaka doing the same. So there's several ways of going about this. Chris talked about this. So pulmonary artery to left atrium does not require a pump. It's applicable to right heart failure with high PA pressure. So it's a reasonable approach. It has been done since 2007. This is the group in Regensburg, Germany, who bridged this woman with cystic fibrosis to transplant using PA to LA. And that's kind of the easiest thing to do. There's no lung device that works well for it. You see the Nova lung being used here because it has the lowest resistance, but there are on the development even more oxygenators with lower resistance. Another way to approach that is RA to PA, and again, Dr. Bermudez talked about this. This happens to be a case of Bart Griffith at Maryland, but that works very well and has the advantages. The blood goes into the pulmonary circulation, so all the little crumbs and clots which will come out of the oxygenator go to the lungs, not the brain. And we would like to see that this eventually will be the way we wind up. This is Maryland's, this is Pittsburgh's version of that. This is the so-called tandem life approach that Chris talked a little bit about. So all these things are on the horizon, just moving from laboratory to clinical trials, and will be in your practice pretty soon. Finally, with ECMO 2, the era that we're currently in, there are some practical issues that you are very well aware of. First is education. So most intensive care docs, especially pulmonologists, but even cardiologists, don't understand this. They don't understand how ECMO works, so they do it badly and the patients die, and it's sad for you because you understand it, and how you're going to go tell the director of the ICU who doesn't know what he's doing, you're going to have to do that. So this is what ELSO does. They're trying to educate people on how to use the technology that leads to certification. These people have passed exams and credentialing within the hospital. We're only going to let people who know how to do this run the ECMO program. And finally, the personnel where you come in. So as you heard earlier from Tom, we've all gone to the single caregiver. The one person who has to be there is going to be the nurse. So the question is, the nurse needs some level of support, and whether that's going to be a specialist who's a nurse trained to do that, whether it's a perfusionist or some other type of people we will see. It's evolving around the world to be all perfusionists. Many, especially the places that have started out with ECMO in the last 5 or 10 years, the bedside nurses run it, and when they need help, they call the perfusion team, and that will happen more and more to all of you. Finally, just a couple of things to tease you about different applications for this technology. One is this. The biggest problem in neonatology is extreme prematurity, as you may know. So if your baby's born at 24, 5, 6, 7 weeks of gestation, the lungs aren't ready to breathe. Most of those babies die. Some of them survive. Many of those have brain damage. So we have a program underway to try to solve that problem, basically using a variation of ECMO to simulate the placenta. So we maintain the fetal circulation in lambs and wait until the lungs have grown to the point where they can recover. We've been at that for several years, and we think it's now working. We're doing this pretty routinely now. And finally, I already mentioned EDCD, using ECMO to resuscitate organs in people who are dead. And we've learned that you can be dead for an hour and still get back organs for transplantation. But you wouldn't want to transplant them because you don't know if they're going to work or not. So the other application to that is ex vivo perfusion. Some of you are involved with this. If you're doing heart transplant or lung transplant in your center, you know that if you get a donor for a patient, you have about 6 hours from the time you take that out and put it into a patient. But suppose you could do that for 3 days. Then you could have all kinds of time to decide whether to transplant it or not. If it works, not only that, to improve its thrombogenicity, to improve the immunogenicity, send it around the world to someone who's a perfect match. Wouldn't that be great? The secret to that is long-term organ perfusion. No one's ever been able to do that. We're working on that ourselves, and if I can click on the, there.
All right, again, EVHP 522, 2017 without pericardium. This is hour 72.
For
Still looking
3
great.
days. Suppose you could do this
It actually picked up speed.
routinely for hearts and other organs. That's pretty exciting stuff. We think that's coming. So finally, where we'll be in 10 years, patients on ECMO for cardiac or respiratory failure will be awake, breathing spontaneously, extubated. The indications will be 50% mortality risk, not 90% mortality risk. We'll be going without systemic anticoagulation. The system will be kicking under the bed, very automatic, so we don't have to think about it. And the applications in cardiac failure or respiratory failure will be the things that we just listed there. So look what's coming. You're going to have a great time in the next 10 years or so. Thank you.